Hello everyone, welcome to a series on valvular heart diseases. In this episode, I am talking about aortic regurgitation. Before getting into the topic, let's see something about aortic valve. In general, it is a tricuspid valve, that is with three cusps, 1 and 2 and 3. And closure of it happens before the isovolumetric relaxation, so that during diastole, no blood flow happens between left ventricle and aorta. Let's see the cardiac cycle. Here we describe cardiac cycle, that is the systole and diastole of ventricles. The systole, which is zero point 0.3 seconds, comprises of isovolumetric contraction, rapid ejection and reduced ejection. And then diastole, which comprises of protodiastole, isovolumetric relaxation, rapid filling, reduced filling and atrial systole, which has 0.5 seconds. The cardiac cycle should be known to learn about the hemodynamics of various valvular heart diseases. So it is important to learn this. Then aortic regurgitation. Here the aortic regurgitation is the backward flow of blood from aorta into the left ventricle, backward flow. It's due to an incomplete closure of the aortic valve. Here we see a simplified diagram of heart chamber. Right atrium, right ventricle and left ventricle. Here the normally flow during systole from left ventricle to aorta and no flow occurs during diastole. But in aortic regurgitation there will be abnormal backward flow from aorta to left ventricle chamber. See here mentioned the regurgitation flow, and you can see in normal there will be normal thickness of ventricular wall and chamber size is normal. Then see its etiology. The etiology is by valvular causes and root causes. Let's see valvular causes. Here congenital cause. The congenital cause is by quadricuspid valve, that is 4 cusp. So it is remembered by a mnemonic: increased cusp, increased regurgitation, that is IR, increase and regurgitation. Here you can see it is quadricuspid valve, 1, 2 and 3 and 4. 4 cusps are present. And then other causes are rheumatic heart disease and destruction of valve leaflet by various causes such as infective endocarditis, trauma or arthritis. Then let's see root causes. Root causes by diseases such as Marfan syndrome, Ehlers-Danlos syndrome and aortic dissection and syphilitic aortitis. It's an important cause, and hypertension related aortic dilation. It's also an important cause. And then ankylosing spondylitis. Then let's see pathophysiology of aortic regurgitation. Due to regurgitation, there will be a backward flow from aorta to left ventricle. Here you can see in this picture. This causes an increase in volume, that is, an increase in left ventricular and diastolic volume because of backward flow, and which leads to volume overload. And due to the increased volume, more volume is ejected out, so increased ejection fraction. And due to this increased volume, the chamber size increases, left ventricular dilation, and to push out the increased blood, there will be hypertrophy, eccentric hypertrophy. And diastolic leak. It is the regurgitation occurs only during diastole, because in systole there will be normal forward flow from left ventricle to aorta, but in normal case there will be no flow in diastole, but here regurgitation occurs during diastole from aorta to left ventricle, so that the systolic blood pressure is increased because of increased ejection fraction, and diastolic blood pressure is decreased because of diastolic leak. Then here is the eccentric left ventricular hypertrophy. Here you can see the eccentric hypertrophy because of volume overload. That is, the size of chamber is increased along with hypertrophy of the ventricular wall. Ventricular wall size increases and chamber size increases. Then let's see clinical features. Here the symptoms are discussed. Let's see. In mild to moderate aortic regurgitation, mostly it's asymptomatic and there may be palpitation because of volume overload. But there may be an nocturnal angina and dyspnea. It's because during sleep there will be bradycardia, which causes increase in diastolic time. The diastolic time increases so that there will be more regurgitation, which causes nocturnal symptoms. And in severe aortic regurgitation, breathlessness and angina will be present normally, as the compensation by increased ejection fraction will be lost because of increased aortic regurgitation, which leads to left ventricular failure. Then let's see signs. These are the signs commonly discussed in CVS and valvular heart diseases. Let's see one by one. Pulse. Here the pulse will be collapsing pulse. That is, there will be rapid upstroke and rapid downstroke, and ill sustained and high volume. The rapid upstroke is due to increased ejection fraction, and the rapid downstroke is because of backward flow during diastole. And increased high volume is because of high ejection fraction, and ill sustained is because the sudden backward flow. Then let's see blood pressure. The blood pressure here, the pulse pressure will be widened. It's because, as earlier mentioned, the systolic blood pressure increases and diastolic blood pressure decreases, so that the difference, which is the pulse pressure, will be more. So it's widening of pulse pressure. And then JVP. Here there will be no change in JVP, as it is a left-sided heart disease. And apex here will be hyperdynamic, that is, increase in volume. It's due to increased ejection fraction. And rapid rising, it's due to rapid contraction, and it's longer than usual. It's because due to more flow of blood through the aortic valve. And hyperdynamic apex are commonly seen in volume overload and eccentric hypertrophy states. Then heart sounds. Here the S1 will be soft. It's because of premature closure due to increased diastolic volume. And S2 may be loud or soft. It's depend on the causes. In root causes loud and valve causes it's soft. And S3 is present in case of left ventricular failure, and S4 will be absent. Let's see the murmur. Here the murmur is Yali diastolic murmur. Here the murmur is diastolic because during systole there will be normal flow from left ventricle to aorta, and the regurgitation happens only during diastole. So it's a diastolic murmur. And how it is Yali diastolic? Because during diastole, from the starting of diastole, there will be regurgitation flow, and it is decrescendo. It's decrescendo, that is, it's high at the earlier stage and later it decreases. It's because during earlier stage there will be more regurgitation flow because of more blood, and then during the process of diastole the murmur decreases, so it's decrescendo, decreases. and the murmur will be high pitched so that it will be heard by the diaphragm. The high pitched murmur mostly covers large area so it can be heard well with the diaphragm. And then other murmurs. Here there will be a systolic murmur. It's because of increased stroke volume. During systole there will be a murmur. And Austin Flint murmur. It is one of the characteristic murmur of aortic regurgitation. It is due to an regurgitant jet which produces fluttering of the mitral valve, and in severe cases it causes partial closure of anterior mitral leaflets, and which leads to a functional mitral stenosis, so that it's a mid-diastolic murmur. It is also present, that is a mid-diastolic murmur is also present in mitral stenosis. Here it's a functional mitral stenosis, so it's a mid-diastolic murmur. These are the other peripheral signs seen in aortic regurgitation. You have to memorize all these for various exams. And then this table comprises all the signs in case of aortic regurgitation. And then these are the important points to remember. Bradycardia prolongs diastole, so increased regurgitation, and vasoconstriction increased regurgitation, because in vasoconstriction the pressure in the aorta increases, so backward flow will be more. And here you can see a statement: exercise makes AR patient better. It's because during exercise there will be tachycardia, so it decreases AR, and also there will be an vasodilation, so it decreases AR. And then severity. Here severity is by 55-50 rule. That is, LV ejection fraction if less than 55, it's severe, because normally in earlier stage there will be increased ejection fraction in aortic regurgitation. And then left ventricular end systolic dimension, if more than 50, it's severe. Then let's see diagnosis. The diagnosis is by gold standard method, that is transthoracic echocardiography, and other means of methods are ECG. In ECG there will be left ventricular hypertrophy and chest X-ray. In chest X-ray you can see cardiomegaly, and then dilated ascending aorta will be present, and cardiac catheterization. It's only needed when echocardiography is inconclusive, because it measures the regurgitant volume directly, and it's easy to diagnose the disease. Then let's see management. Here the management is by valve surgery. It's the definitive management, and medical management is only supportive, and it's by vasodilation. As earlier mentioned, vasodilation decreases pressure in the aorta and decreases regurgitation. And these are the indications as per Harrison, that is symptomatic. Here in aortic regurgitation, only symptoms occurs in severe conditions. So in severe aortic regurgitation, here it's 55-50 rule. It's the rule for severity of aortic regurgitation. And then these are the two methods, that is surgical aortic valve replacement. It's an open method, so it's used in low to moderate risk patients. And then catheter based method, which is minimally invasive, and it's recommended in older patients and high surgical risk patients. Then do like, share and subscribe my YouTube channel. Thank you.